place. How are you, Kevin? Good to see you. Yes, I hear ya. I hear ya. Okay. We're just going to wait for our panelists to show up. Absolutely can. In fact, I'm going to go join you. Beth, do you know where the coffee is? Do you want to join us? So, okay, ISIS. I mean, you probably know. And I think I'm just wondering it's been excellent. Good morning. How are you, Becky? Good
Good to see you. How you doing?
Good. Did you have the test?
No, 2 weeks. 21st.
Oh my gosh.
We're winding down. I was gonna say 25.
Oh yeah, sure. I'm sure that'll work great. Let's see here.
I have to call Pedro really quick.
Okay.
What can I do for you at the moment?
I'm just trying to make sure that you can pray to the technology gods.
Well, Lori, you're my.
How about that?
technology
How about
god.
that right there?
Are you having glitches? Is something?
Well, I can't, I'm trying to get the panelists in, so we'll have to see if she can. I'm trying to, no, it's okay. It's okay. We'll figure it
Luckily,
out.
you have a very patient audience.
Yes, I do. Thank you. Thank you. There, she got in. She got in. There she is.
Morning.
Good morning. Good to see you.
You too.
Oh, good. Thank you for you got in finally okay?
Yeah, well, you had 3 different invitations. I don't know if they were all the same. And then I found HOC panelist as the correct password. But
Okay.
so I was trying all 3 of them.
All 3 of them. There you go. Well, we've got a room full of volunteers here, and hopefully we'll have some signing in here shortly. So looks like we've got some of them have already joined, and then we'll have a few more coming in just a minute. So
is my sound okay?
Yeah, your sound sounds good to me.
Okay.
I've got it turned all the way up, so hopefully you know, everything's good, and then we'll start recording.
Is, about the slides. Are you going to have them?
Yeah.
Or am I able to should I share my screen?
If you want to share your screen, that works just fine, or I can do it for you. It's your choice. I've got them both up here.
If you do it for me, am I able to advance it on my own, or do I have to?
No, I will. You'll have to shout out to me to advance.
Okay, let me try sharing my screen right now then, and so that I can advance them. Right?
Okay.
Does that work?
Yeah.
Like if okay, just a second.
Yep. Go ahead.
Okay, and then do you see it?
I see it. It's a little small, so you may have to do the presentation. There you go. Much better.
Okay, and then
Excellent.
let me
That's
try
perfect.
advancing. Oops. Okay, up here. Okay.
You should just have to push your cursor. There you go. Yep,
Yeah,
looks
yeah.
good. Looks
Okay,
good.
let me minimize this then, I guess, or stop sharing.
Okay. Okay, there we go. Hey there. Good morning, everyone. If you wouldn't mind just making sure you sign in for attendance so that we have you're there.
For any of my volunteers.
Okay.
An email with the dates and.
That sounds good. Yep. Yeah, we'll make sure we get that caught up. Let me see here. I've got to get Barb.
I wasn't on there, so I just signed myself.
Okay. Hmm? Oh, it was great. Yeah, it worked out really well. Hey, I'm sending it to you right now. Yeah, panelist password. Yeah, I think go ahead and log in. I think I can make you a panelist if you log in with just the general meeting instructions. Let me see here. Try HOC, capital HOC panelist, capital P. Yeah, panelist. Okay, good. We'll see you soon. Bye. Okay, we're just waiting. Barb's logging in right now, Laura. So be just
She's
a
supposed to
minute.
speak first, isn't she?
I'm sorry, what?
Is
Yeah,
Barb
she's
speaking first? Yes.
Yeah, she's speaking first.
Okay.
There she is. Hey, Barbara. Hey there. Good morning. You're muted. Here we go. Let's see. Good morning, Barb. She's getting her earbuds in.
I need to learn how to do that. I don't know how to sync my personal earbuds to this laptop.
Yeah. Good morning, Barb. Can you hear me? Still working on it?
Turkey one.
Okay. Excellent. Barb, can you hear me? Can you go ahead and unmute yourself?
There we go.
There,
Can you hear
excellent.
me?
We can hear you now. Yeah, just test your sound real quick. Just say 1, 2, 3, 4. Can you just test your
Me?
sound? Yes, Barb,
Oh,
please.
1, 2, 3, 4. Hey, Laura.
Hi,
Everybody
good
can
morning.
Great, excellent. Well,
Hey.
Gonna go ahead and just get started with our webinar here today. So everyone knows I am recording. That is one of the benefits of coming in the in-person presentation is you don't get recorded. But we have approximately 15 volunteers in our Blue Ash community room who have attended today. And we have about 15 that are also online, which I'm really excited about. My name is, let me go ahead and start the recording so everyone is aware. All right. And we're going to go ahead and record. So good morning, everyone. My name is Lori Asmus. I'm the manager of volunteer holistic services in the Lasting Wish program at Hospice of Cincinnati. I'm very excited today to offer our first continuing education for volunteers for our 2023 calendar year. And very grateful to our two panelists, Barbara Rose. Barb, raise your hand. There we go. And Laura Alexoff, who are amazing leaders within our Hospice of Cincinnati and long-time experts in the field of death and dying. So we're very grateful for their time today. Just a few housekeeping items. For those of you all on the online, we have turned off your cameras and we would like you to use the chat function. That is at the bottom right-hand corner of your screen. You'll see a little comment bubble. If everyone can just type good morning in your name, that's how we're going to take attendance this morning. So go ahead and shoot me a chat. If you have any questions, we ask that you, if you're online, that you chat your question to us. We will not be using audio this morning. And if you're in the room, we ask that you use one of the notepads to write your question and pass it forward. And we'll ask that at the presentation. So I'd also like to thank and recognize all of the people who have decided to join the doula cohort. So I'm very, very excited that we kicked off our volunteer doula program this year. This is the first of 4 required classes for that. We are also videotaping if people want to watch that on demand. And I'm proud to say that we have had 29 volunteers that have stepped up to join that program. It's really, really exciting how beautiful it's going to be to the patient and the caregiver experience. And our leadership is very, very excited about that. So let's go ahead and get started. I'd like to introduce Barbara Rose. Barbara Rose is the Senior Project Administrator for Advanced Illness Programs at Hospice of Cincinnati and has been since 2012. Barb has successfully pursued and retained 2 multi-million-dollar grants for one, Conversations of a Lifetime, which is a multifaceted community project to improve advanced care planning in the area's health systems and community, and 2, Palliacare of Cincinnati, which is a home-based palliative care service with nurse practitioners, nurses, and social workers providing supportive care in the home to patients with life-limiting illness. Barbara also provides strategic and administrative oversight for several inpatient palliative medicine teams and a group of hospice nurse practitioners. Prior to her work in advanced care planning and bettering end-of-life care, Barbara was the program director of the Ohio Perinatal Quality Collaborative, which is a successful statewide perinatal improvement collaborative impacting Ohio's 140,000 annual births. Barb has a master's degree in public health from the St. Louis University and 40 years of experience in the field of nursing, public health, physician practice, program management, community-based health improvement. She lives in Morrow and an agri community with her husband and their dogs, Gibbs and Max. And she's a proud mother of triplets, 32-year-old triplets, and a 9-year-old grandson, Christopher. And she's just an overall one of my favorite people at Hospice of Cincinnati. So welcome, Barb. We really appreciate you being here. And I'm going to go ahead and launch your presentation for you.
Thanks, Lori.
You're welcome. Now, I will introduce Laura after at the next presentation. Okay, but thank you for bringing that up.
And
okay.
Lori, let me know questions as they come up. If I don't see them in the chat, okay. I'm happy to have back and forth. Just interrupt me or let me know if there's a question that comes up. Can you put that in presentation mode? The little
yes, I can.
slide, the little screen. So this is actually what a great way to start my week, is talking about this discipline of palliative care, which is, in my estimation, just a really terrific space where the healthcare team of specialists can really help patients with serious illness and their families figure out what's going on and what the future looks like. So before I start to talk a little bit about the palliative serious illness care, and then Laura is going to talk about hospice care, and I think we give this group kind of a really nice overview tag team. So we will both kind of weigh in as you ask questions. But I want to just give a quick shout out to Lori. I'm so excited about almost 30 end-of-life doulas really interested in becoming, in Lori's term, super volunteer. It is absolutely the perfect match for the work that each of you have done on your own to become an end-of-life doula. And with all of the need we have in serious illness care and hospice care, it is just a perfect intersection of your individual interests and then the value that you bring to patients and families. And it's hard not to be excited by Lori's enthusiasm and energy around this and all of her other volunteer experiences. And then a quick shout out to Laura as well, who has had a great background in hospice. In the last couple of years, she's really helped launch a couple of programs, our Social Connections program, and then the Advanced Cardiac program in hospice care. So really great partners. Go ahead, Lori. So for the next 20 minutes or so, I'm going to just kind of give an overview. I mean, slides kind of guide the content, but I love speaking to groups, healthcare groups, community groups, this end-of-life doula group, just around what palliative care is, how it fits in the structure of serious illness care. It's different than hospice. Lots of misconceptions and misunderstandings by community members, as well as physicians and other providers in the healthcare system. So this is the definition that I usually start with, and CAPC is one of our professional organizations, the Center to Advance Palliative Care. This is CAPC's definition, and so I find it really helpful to start with this definition, regardless of who the audience is. And basically, it's medical care focused on the relief of symptoms and stress of serious illness with a goal to improve quality of life. So interestingly, palliative care as its own discipline has just been around since 1999, so 23 years or so. And I think that's part of the reason. So hospice has been around since the mid-70s. But I think part of the reason there's lots of opportunity for education and just defining what palliative care is, perhaps what it isn't, but where that space is that it can make the most difference. Okay, Lori, next slide, please. So this is just kind of an overview of, so HOC Navigators is what is sort of the umbrella organization of where Hospice of Cincinnati provides hospice care. But over the last few years, so Conversations of a Lifetime was our community-based advanced care planning, and then we started this home-based palliative care. Then we brought on already established in the hospital palliative care programs, and then also have some nurse practitioners out in the Mercy Hospital. So we've got quite a menu of advanced illness, which is just another phrase for describing palliative care, serious illness care, advanced illness care. So this just kind of is a continuum of programs and services offered by HOC Navigators, and then under that, the two Palliative Care Cincinnati, and then our hospital-based and clinic-based. So the discipline or the specialty of palliative care can be provided in a variety of settings. If someone's in the hospital, if there's a clinic available, typically with perhaps a cancer clinic or a heart failure clinic, and then our home-based program. And I'm going to focus mostly on the home-based program, but I just want to set the stage that if you think of palliative care as a specialty, people can receive that care in the hospital, in a clinic setting, or in the home. And I think in the home is where we make a particularly big impact for families and patients with serious illness. Okay. And this is just, so Palliative Care is our home-based program that we started in 2017, and just very simply helping folks with serious illness live their best lives. And when I say serious illness, here's what that means. That means a life-limiting condition that is not going to get better, that could absolutely contribute to what that person dies from. Oftentimes causes a lot of symptoms, people in and out of the hospital. So I'm thinking heart failure, COPD, so chronic obstructive pulmonary disease, advanced cancer, kidney or liver failure, advanced dementia. So that's a number of conditions that we see our loved ones and our patients might present with. They're not necessarily terminal in that last 6 months or year of life, but they're experiencing a lot of symptoms, and there's less and less sort of treatment that's actually going to make a difference in improving the outcome of that condition. Okay, next slide, Lauren. So this is just a quick overview of how extensive our palliative care service line is. And so for those of you in the audience, you may know that HOC Navigators is part of the Tri-Health system, but we see patients and families and physician referrals from across the community. So if you're getting your care at Mercy or the Christ Hospital or University of Cincinnati or Tri-Health, you can certainly get palliative care in the home. And then also this sort of outlines where we have palliative care in other settings. So Bethesda North, Good Samaritan, and 3 of the Mercy Health hospitals, Anderson, West, and Fairfield. So it's a pretty big practice, 6 physicians, 11 nurse practitioners, and 4 nurses. Okay, next thing. And this just gives kind of, you can see I pulled these slides from probably more business affiliated presentations, but I like to set the stage for what kind of volumes we see. So we take a look at on the program side, how many patients are we serving, how many visits did we do, how many admissions did we have. So the inpatient Tri-Health team has served almost 2,800 patients. So far this fiscal year, so our fiscal year is July to June, almost 1,100 patients in our home-based palliative program, and almost 3,000 patients across the three Mercy, and actually seeing that Anderson isn't on here, but across the 3 Mercy programs. So pretty good penetration, right? And not everybody is eligible for a palliative care consult, but this kind of gives a sense of, in the first 6-7 months of the fiscal year, how many patients we were able to touch and hopefully help. So I'm going to talk mostly, like I said, mostly about the home palliative care service for those with serious illness. So a couple of things around the structure of this. So this is, think of if you've ever had an interaction with a nurse practitioner who are so building on their nursing background, they go on for additional training to become a provider. So not at the physician level, but an independent provider. And that's sort of the crux of what this home palliative care service is. So we send that very skillful palliative nurse practitioner into the home. So we work with collaborating physicians. So if your person has a primary care physician or a specialist who's managing their illness, so it could be a cardiologist, pulmonologist, oncologist, but we work in conjunction with the physician who is managing that serious illness. So it does require a physician referral. Now, family members will call the office and say, I want my mom to have palliative care referral, and we'll take that on. But we do need to collaborate with a physician just by the nature of palliative care being a specialty practice. And so think about somebody, so a typical person that might get a referral to palliative care is an 85-year-old man with congestive heart failure who's been in and out of the hospital for 3 times over the last 2 months, right? So very symptomatic, not sure what to do. We call 911 or a family member takes them to the hospital. they get admitted. They may or may not have a consultation with an inpatient palliative medicine, and then they go home, and the family wants to do something different. Every time dad, yeah, Lori, do you have a question? Or is there a question?
Yeah, we did get a question. The question was, when you say in the home, in hospice care, that can include a nursing home. Does that include a nursing home with palliative care?
Yep, that's a great clarified question. For the most part, we've got 5 nurse practitioners for about a 4 or 5 county area. We do some limited consultation in nursing homes, but have found that we have way more demand for consultation than we have providers. So we have found that we can make the most impact in the patient's home. Now that could be independent living or assisted living. There are so many additional levels of administrative issues that need to be part of a nursing home consultation. So medical director, director of nursing, finding the nurse, getting information from the chart, making sure that that there's a palliative need that we can address, making recommendations, which is what nurse practitioners are quite good at doing. There's a lot of additional administrative time that is required for a nursing home consult. So about maybe 5 or 6% of our overall volume is done in nursing home. We do have a growing number of consults happening in independent living and assisted living.
Great, thank you.
Yep. So, what do the nurse practitioners do? And I think in the coming slide, I've got a little bit more detail, but don't change it yet, Lori. So I think the 2 things that I want to make sure are clear is that this is a medical specialty. And so it's structured much differently than hospice care. So if you go see the ENT doctor or you go see the cardiologist, that office bills your insurance or bills Medicare, and sometimes you have a copay. That is the same structure for home palliative care. Because we're sending a provider into the home, and she, in this case, all of our nurse practitioners in palliative care are female. She does an assessment. She collaborates with the referring physician, and then she sends a bill to insurance, and then oftentimes there is a copayment for the family. Sometimes that's a barrier for care, but the structure is just like if you were going to a clinic or a doctor's office. It's just that we're sending the provider into the home. And then in the office, so the 5 nurse practitioners are out in the field. In the office, we've got 2 nurse coordinators, social worker, office coordinators, and then we have a physician who oversees the practice, particularly provides oversight for the nurse practitioners. So it is sort of, again, if you think of a doctor's office with all of this support, this is a practice that sends the provider into the home, and then the nurses and the social worker and the office coordinators work with the patient, the family, our nurse practitioner, and then whoever the referring physician was to make sure that the care is coordinated and it's not duplicated in any way. Any questions about the structure?
A show of hands in the room. How many people is this new information for? Right? You think of somebody in your neighborhood, your church, your home that could probably benefit from this level of coordination that's maybe not hospice ready, right? Huge service to our community. Thanks, Barb.
Sure.
Oh, I got a hand raised. Hold on a second. Let me see what this says.
Yeah.
Is this service covered by Medicare? That is a question.
It is. There is a copayment. So just as when you go to the doctor's office, 80% is paid, 20% copayment. There is a copayment. But yeah, it absolutely is covered by Medicare.
Yeah. And I had a question. Yes, you will get copies of these handouts. There we go.
So the other thing to say about palliative care under HOC Navigators is that our service is the only comprehensive home palliative care program that is affiliated with a health system. There's a couple of other home palliative care programs that are affiliated with health plans. So Humana and Anthem have a contract with national for-profit palliative programs, but ours is the only, PalliaCare is the only one that's local, that's affiliated with a health system, and I venture to say the quality and the breadth of what we do is a bit more expanded than what you might see with a health plan. Okay, next slide. I want to keep moving because I know Laura's got a lot of good information to cover. So just briefly, here's the kinds of symptoms that the nurse, so one of the values of sending the nurse practitioner into the home is that she gets to see the whole picture of what's going on with the patient, their living situation, their support, their lack of support, their drawer full of expired medications, their sink that doesn't work, and all those symptoms, those physical and emotional symptoms that take people back to the hospital. So it doesn't matter so much what the serious illness or the diagnosis is, but these are the kinds of things that make quality of life not very great when you have a serious illness. So shortness of breath, fluid retention or edema, fatigue, poor appetite, difficulty sleeping, pain associated with that serious illness, anxiety, depression. Any or all of those are what our nurse practitioner and team are really skillful at evaluating and then making recommendations. Depending on the physician who they're working with, sometimes those docs just say, go ahead and prescribe what you think would be helpful. And then some physicians like to do the ordering of the medications or whatever with the nurse practitioner's input. So either way, it doesn't really make a difference to our team, but what they're really good at doing is looking at the whole picture and then also just really communicating with patients and families. I'm going to say a little bit more about that later. Next slide. So in addition to physical and emotional symptoms that take people back to the hospital and just don't feel good and take up a lot of energy and take up financial resources, a lot of times the second piece that this team is really good at doing is goals of care conversations. So that can be any or all of the list here. So that could be advanced care planning, that could be advanced directives, the living will, and or the healthcare power of attorney. It could be a goals of care code status conversation about a do not resuscitate status. And then it can also include an emergency health plan. What took you to the hospital before, and what can we do if that happens again so you don't have to go to the hospital? And so the heading of this slide is that for some people, avoiding the hospital at end of life is a goal of care. And so one of the things the palliative team is particularly good at doing is helping patients and families talk through those scenarios and put things in place. And so it's not restricting going to the hospital. There's no restriction on going to the ED, emergency department, if that's what people want to do. But we see over and over and over patients and families asking for it. We don't want to send Grandpa back to the hospital because that's just not where he wants to spend his time. Help us figure that out. And sometimes figuring that out means a referral to hospice care. Okay, next slide, Lori. This is, I won't go over this in depth, but this is a tool that we put together a while ago that just kind of outlines the differences between community-based or home-based palliative care, hospice care, and then home care. So many of you might have had experience with people who have a home care nurse or home care aide. So for IV fluids or IV antibiotic or a dressing change or a check-in from home care. That is not what home palliative care is. However, they work very nicely in conjunction. So think again about the nurse practitioner and her team going into the home to figure out what are the palliative needs. And then the home care person is sort of an adjunct to that. So if somebody needs in-home Lasix or an in-home antibiotic or a wound care, our nurse practitioners don't do that home care. They're at the provider level, figuring out what would be beneficial to reduce symptoms and to improve goals of care. So there's a lot of good information here, and especially Lori, if they're getting getting the slides, we'll go ahead and move on. And then I put in just a couple of, so this is one of my favorites. We, so when we were first starting Palliacare, and I was doing a lot of presentations, particularly to some of our provider groups and some of our community groups. If you think, so this actually dates me, and perhaps for folks, some of the folks on the call, you have to be of a certain age to know who Mary Poppins is, but just the creativity, the creativity of Mary Poppins opening that bag and pulling out all kinds of things to serve in the moment to really help her charges feel better. So Mary Poppins, it is one of the sort of metaphors I use when I'm talking about the value of home palliative care. All right, so
and I'm going to venture to say, I'm going to add, Barb, that might be a little bit what our doulas will end up doing too, is a little bit of Mary Poppins work. So feel free to borrow that metaphor and that slide, Lori, because I would agree with you. I think there's a lot of appropriate opportunities with Mary Poppins and serious illness care and end of life. So I'm going to go through these fairly quickly, Lori. I'm not sure. So I was just thinking about a little bit more detail, particularly for this audience, about code status. So when we say goals of care conversations, we mean everything from what's a good day look like, to who would speak for you if you couldn't speak for yourself, to DNR, do not resuscitate status. So you probably know that each state has their own kind of forms and their own rules, and many states have a MOLST or POLST form, which I'm going to show. These are the two delineations in Ohio if you don't want CPR, you don't want to be resuscitated. The DNR CC, which is comfort care, which means don't put a tube down my throat, don't pound on my chest, don't do that. I just want comfort care. And this guides the emergency personnel like an EMT or paramedic, and it guides at the hospital in the emergency room. DNR CC arrest, that's kind of that gray area where people aren't quite ready to say, don't resuscitate me, I think I might want this or that or the other. For healthcare professionals, it's a little bit more of a gray area, particularly in the hospital setting, but it's still a bit of a guide, particularly out in the home or in the community. Next slide, Lori, this is just a copy of the MOLST form. MOLST stands for Medical Orders for Life-Sustaining Treatment, MOLST. There's a companion form called the POLST, where medical is substituted for P for physician. Essentially, a DNR and a MOLST form needs to be signed by a healthcare provider. This is not something you can do around the kitchen table or with your attorney. This is healthcare provider driven. What we do in home palliative care, so this is a picture of the Ohio DNR, which has CC or CCA for CC arrest. Sometimes what our nurse practitioners will do, so Ohio does not have a MOLST or POLST form in place. That's a different presentation, lots to tell around that story. But what our nurse practitioners will sometimes do, if a patient and family are on the DNR CC arrest, that sort of gray area, they will also complete a MOLST form, which gives an opportunity for patients to say, I want this, I don't want this, please follow these directions. Again, it's very healthcare provider driven, and it's for a healthcare setting. And then next slide, and I'll just kind of blow past that. That just kind of gives an overall definition of the MOLST form. So I just wanted to spend a few minutes on, sort of described what palliative care is, the benefit in particular in the home, but I want to also be fair to my inpatient teams. The nurse practitioners and physicians and nurses who do palliative care in the hospital do equally as valuable work
within the walls of a healthcare setting. But this is just to sort of demonstrate to our audience that we really keep an eye on process measures. How many referrals are we getting? How many people are we seeing? How many people go to hospice care if that's aligned with their goals? How many have an advanced care planning note? We also look at a lot of times when people get palliative care, because they actually go to the hospital less, we actually see some cost avoidance opportunities. So if people are in palliative care getting their goals met, they're not going to the hospital, their care tends to be a bit less expensive than folks who are going to the hospital more often. And then we also do a 5-item symptom score. So I'm going to say a little bit about that. So when we started this program, the home-based program in 2017, we had a very skillful physician who was in Cincinnati for a couple of years with her husband from the UK, and she had 10 years of home palliative experience in the UK. And she said to me, as she was helping me define this program, what are we going to do and how are we going to know we're making a difference, right? It's not just about how many referrals did you get and how many people did you see, but these are folks with serious illness who are symptomatic and not feeling great. How do we know that we're making an impact, making a difference for their quality of life? So we adopted this IPOS, which stands for Integrated Patient Outcome Scale, IPOS. And so for every, go ahead and go to the next slide, Lori. So for every patient in the home, we started it with the home, every time the nurse practitioner visits a patient, she asks these 5 questions that we put into the electronic medical record. She asks them a question about their pain level, their shortness of breath, their anxiety, their feeling at peace, and about their information needs. So I don't have the questions here. This is kind of, this is just an overview of the domains, these 5 domains. And so we look for a reduction in the number. So the blue bar is the initial question, the initial time it's asked, and then the green bar is the most recent time. And so you can see the little annotation there that the down arrow. So as the number goes down, that actually demonstrates an improvement in symptoms. And so we do a snapshot of this IPOS 5 Integrated Patient Outcome Scale. We do a snapshot once a quarter for patients who have been in our care on the home-based side for 30 days or more. So we've learned that we can do a lot in the first 30 days, but we may or may not make a difference in these 5 symptoms. So over the last 5 years since we started this program, every time we do this snapshot of initial IPOS and most recent IPOS, we demonstrate a reduction in symptoms, individual symptoms, and a summary reduction of symptoms. And so we were so pleased with this particular metric that we brought it to our TriHealth inpatient teams and said, would you guys consider doing the IPOS 5 on our inpatient palliative care consults? I don't have that data up there, but we've done that over the last year. And so we have a goal. At home or in the hospital, we want to see if we're making a difference in helping people feel better. Quality of life.
Question, Barb.
Lori.
They wanted to know a little more, what does information needs? What does that metric represent?
So it's fairly open-ended, and I don't have the question in front of me, but essentially the nurse practitioner or the provider says, based on your experience, do you have all of the information you need about your condition and about what we're doing to help you feel better? I mean, that's kind of a paraphrase, but it's general, right? So sometimes people know that their serious illness diagnosis is causing them all these symptoms and they're not going to get better. But a lot of times, I mean, we hear it over and over, a lot of times no one has really sat down and said, so Mrs. Rose, your heart failure is not going to get better. we can manage the symptoms, but it's not going to get better, and it's likely going to, you know, get worse over time. That would be considered an example in that particular patient of an information need.
Okay, two other questions from the room. Is Palliacare a for-profit organization or entity for HOC?
No,
No.
sir, no, ma'am, it is not. We run at a financial deficit because the nurse practitioners bill for their services through insurance. And because we have this whole multidisciplinary team, we run at a financial loss, pretty significant financial loss every year. So it's not anywhere near profitable, but because it aligns with the overall mission of HOC Navigators, and because a good portion of Palliacare patients go on to become Hospice of Cincinnati patients, the organization makes a subsidy for the in-home palliative care program. Yeah, that's a great question.
Yeah, we do it because it's the right thing to do, right?
Yep, and because it makes such a difference. Was there another question, Lori?
Yes, there was. Is there you're going to love this one. Is there a role for home companionship volunteers in Palliacare?
Well, Lori knows I would say yes, there certainly is. And Lori will tell me that you know, because of the census in hospice and because of the need in hospice, we're careful in how we deploy volunteers to home palliative care, but the answer is absolutely yes. And Lori has been actually gracious over the years in working with our social worker and nurses when there is a very real, really defined situation when Lori will place a home companion.
Yeah,
So,
how many patients do you have on your census currently right now?
393.
393. Yeah, and just to put that in perspective, we have, I think, 745 in hospice care. And that's just been in the last, 4 years that we've grown to 393?
Yep.
Yeah.
Mm-hmm.
So increasing need there, and we got to catch up our volunteers. So everybody go out and find another volunteer that wants to come and volunteer for Palliacare. Great. Thank you, Barb.
Sure. All right, go ahead. Next slide. This is just kind of an overview of our, you know, our dashboard for each program. We do collect a lot of data just to keep our finger on the pulse of how the programs are running. Okay, next slide. All right. So this part of it is our referrals to hospice, our conversion rates, our length of stay, all that sort of brain program stuff. Next slide. And I appreciate your patience in listening to that. Now I'm going to talk for just a couple minutes about the heart side of serious illness care, because that's the juice and that's what gets us up every day and takes us to meetings that we sit through that we need to on the head side, because the heart side makes such a difference. Next slide, Lori. So you guys have probably seen these two books. These are two of my favorite. Atul Gawande's Being Mortal, written about 10, 11 years ago. Katie Butler, who is a journalist, wrote this book a couple of years ago, Practical Guide to the Good End of Life. If you've not read this, she just did a really nice job of outlining the stages and the different responses to those stages. So just recommendations.
And we have a lending library. Yeah, we have a lending library if any volunteers want to borrow these.
And I've actually got a couple of the Art of Dying Well I could pass along to the lending library. So some of these questions from Atul Gawande's Being Mortal help guide goals of care conversations. So if you've read the book, if you're familiar with this construct, but these are questions that you guys as end-of-life doula volunteers can be asking. These are seeds for goals of care, helping people understand and think about, what do you understand about your illness? What's most important? What does a good day look like? What are you worried about? What are you willing to give up? I love this construct because it's not medical, right? It's not about medication or procedure or specifically symptoms, although physical or emotional symptoms could come up in this. But it's just a construct to helping have conversations with folks who are have serious illness and or who are in hospice care.
Great list.
And then I'm getting ready to wrap up. Next slide. So this is one of Atul Gawande's, one of my favorite quotes of his from the book, that our ultimate goal after all is not a good death, but a good life to the very end. And next slide, Lori. This is a picture of my hospice dog. I foster dogs off and on, and this was a hospice foster dog. When she came to me, she had a long line of terminal diagnoses, and they didn't think that she was going to be with us for very long, and she ended up living with me for 19 months. And this was her service as a hospice dog to my dad when he was in hospice care. At the end of 2018, I made a road trip down to be with my mom and dad and took her with me. And she brought such joy and comfort to, as a hospice patient, to a human hospice patient. And sort of what goes around comes around. So this is really my heart work behind palliative and hospice care.
Oh my goodness.
So,
well, thank you, Barb. We are so grateful for you. We are so grateful for your presentation. And I'm just going to try to figure out how to turn this back around. Pause that real quick. Let's see, stop sharing. Stop. Yeah,
thanks for doing the slides, Lori. I appreciate it.
Oh, yeah. And I have to say, just kudos to you and your ingenuity to provide Cincinnati with this amazing service. We are so grateful for that. And what it has, resulted in for our patients and families. My mom or my mother-in-law was in and out of the hospital a gazillion times. And it wasn't until I talked to Barb that I got the words that we needed to use, which was, can we get her a palliative consultation? It wasn't the hospice word. It was just about bringing in a different perspective. And that palliative nurse practitioner, she was in California at the time, made all the difference in her trajectory and her experience that, I just think it's a growing field. It's one that we're going to see, and it's good for people. So I think I'm going to go ahead and introduce our next speaker. Thank you, Barb, so much for that. It was wonderful. And you all will get to see Barb a lot because she is actually the senior leader that I report to for our doula program. So she's very excited about that and growing. So you'll hopefully get to see her at some of the networking meetings and some of the future continuing education sessions. So now, and I just want to point out, if you're in the room, if you'd like to take a break, you're welcome to. We're not going to stop the session for a formal break, but want you to feel free to come and go as you need to. Our next presenter is Laura Alexoff. So Laura's been sitting there quietly, just beautifully waiting to present on hospice care. And I'm going to read Laura's biography. Laura Alexoff currently serves as the Specialty Programs Nurse Coordinator with HOC Navigators. Laura's primary responsibilities include the newly launched HOC Advanced Cardiac Care Program, which you all have hopefully been hearing a lot about. She also does community education presentations and nursing and social work continuing education credits. She also manages the Social Connections program. So if any of you have had Social Connections patients, she is the one who manages and requests their volunteer service. Social Connections is a program to provide supportive socialization and resources to seriously ill and socially isolated clients and their caregivers. Prior to her role, Laura provided direct patient care for over 25 years at Hospice of Cincinnati in a home care and inpatient setting, and she is a certified hospice and palliative care nurse for 12 years. So thank you so much, and we're glad to have you. She's going to go ahead and provide her own presentation, so thank you.
Yeah, thanks, Lori, and thank you, Barb, for a great presentation. Yeah, and I noticed a couple people, I don't know who's in the room, but I saw Joy and Robert.
Yeah.
They interact with social connections people, and I'm really grateful for them and all of the volunteers. I am going to share my screen now.
Great. Looks good.
Okay. So this is, I'll just say a Hospice 101. This presentation is not so much about actual care, but it's everything, all the background about hospice. And I give this presentation or a version of it a lot of times to the public who don't know about hospice. So my objectives for this presentation is, by the end, that I hope you understand hospice care philosophy, that you'll be able to describe the 4 hospice myths, the top myths, and review facts to dispel them, that you'll know about hospice eligibility, and you'll have examples of diseases that are cared for, that you'll know about the hospice interdisciplinary team and the roles of each, that you'll understand the hospice benefit and what it includes, a little bit about live discharges. Yes, if you didn't know, we do discharge people live from hospice, and then know a little bit about how to refer somebody to hospice. I don't know if you're familiar with our mission statement. Hold on, I'm gonna. Okay. The hospice mission statement, Hospice of Cincinnati creates the best possible and most meaningful end-of-life experience for all who need care and support in our community. And I think this is a good opportunity for me to say, you know, when we think about a hospice experience, an end-of-life experience, we think about the patient, you know, they're the center of it. But I want you to also just have a real awareness that we're taking care of the caregivers, the family of that patient, I think just as much as the patient. And a quick example, you know, with all my years of hospice experience, I once went to a funeral visitation, and I was in line to, you know how you greet the family. And this patient was, you know, in my mind, had a very peaceful passing. You know, we managed all their symptoms throughout their hospice experience. I thought it was very good. And when I got up towards the, you know, up towards the family, I heard the wife say to the person in front of me, "Oh, he had so much pain." And to hear that, you know, that wasn't my impression at all. And it made me feel really sad that, you know, that his wife felt that way. And, you know, and maybe I didn't know how much pain he had. Maybe, you know, when I visited, that was, you know, they kind of hid that from me, or maybe that was just her perception. So just keep that's just an example to keep in mind, that you're taking care of this family just as much, if not more, than the patient, because they're left with the memory of what this experience was. It goes on even after the patient has died. And I'm trying to advance. Oh, there we go. You know, Barb covered this, the difference between hospice and palliative care. So I'm not gonna go into that, and you'll have it in your materials if you want to read it more closely. So I wanted to say, when you think of hospice, a lot of things, feelings and emotions come up. You know, it's all the way from, oh, you know, hospice is just angels sent from heaven. Some are negative. You know, hospice hastened or killed my loved one. Hospice makes you give up hope. The range, you know, grateful. We couldn't have done it without hospice, all of those. So just know that the people that you serve will come into hospice with a variety of feelings and emotions based on what maybe past experience or what somebody has told them, or, TV. A lot of what people have feelings about hospice and end of life is through TV and media. So you just be aware of that. Okay, so the first myth is that hospice hastens death. And it is a myth. And patients are referred very late in the end of their life often, and they're in crisis when they come to us. And it's not that we brought on the death, but it's that's the time they came to us. Also, there are use of medications. When particularly morphine or any of the opioids, narcotics, they make patients and caregivers, especially caregivers, feel very anxious, and a lot of times the use of these medications coincide with end of life, because that's maybe a person hasn't needed those medications up until the end, and therefore, when you introduce those medications, it makes it seem like it was the medications that ended a person's life. But the fact is that enrolling in hospice early can prolong life, and there are studies to show this. There's a number there for congestive heart failure and certain cancers. And then actually one survival is 81 days longer for congestive heart failure patients. And I know that very acutely because of our end-stage heart failure program that I'm involved with now. I see people that really the family or their physician expected the patient to pass away very quickly after coming into hospice, or they thought they were, their condition was very poor. But because of the care we give, a lot of times we improve their health and extend life. And how is it possible? So one of the things is we avoid, when they're in hospice, the risks of over-treatment are avoided. A lot of, some of the things that the treatments they receive are detrimental and to mentally and physically. Being in the hospital, sometimes you're subjected to tests and treatments, and also germs in the hospital. And then we, because we have such, really, one-on-one and close monitoring and care of the patient, they often do better. And then the psychosocial support that we bring. When people feel supported, their immune system is stronger, and that helps with their physical health as well as their emotional well-being. And then the holistic care, that just means we take care of the total person, their psychosocial, their spiritual, their physical, emotional.
Laura, real quick, I had a question on the chat. It says, what does CHF stand for? We love our acronyms.
Yes. Congestive heart failure.
Okay, that's right. That's our advanced cardiac program,
yes.
Right?
Yeah. Okay. So when I slip into those medical acronyms, please tell me. So this is our model of care. Look at there, the volunteers at the very top.
Yeah.
I don't
That's
know
right.
if you all know, but the volunteers are mandated by Medicare that I think it's 5% has to be direct patient care. And we have to prove that we are using volunteers for at least 5%. And
we're 10%. Woohoo!
Yay! Thanks to all of you and Lori's efforts. So there's the whole team, and if you will notice who's at the center of that, the patient and the family. I don't know if you're aware of all those members of the team.
Excellent. And if you're part of the doula program, you will do an IDT observation as part of your final competency. Well, you'll be able to see what the functioning of that reviewing each case it looks like. It's very enlightening. Oh yeah, IDT is the interdisciplinary team. That team that she just showed on the graph, the social worker, the nurse, the physician, the pharmacist, everyone. Okay, great.
Yeah, I
Thank
think I
you.
may talk about that just a little bit more, but down the road here. So hospice is a philosophy, not a place. And the philosophy is that it's for comfort and not for cure. Sometimes our care does end up extending life, as I said previously, but that is not our goal. Our goal is the comfort above all else. To affirm life, to neither hasten nor postpone death. And our focus is on enhancing the quality of life during the end of life. And I like to say simply that it's trying to make a sick person feel as least sick as possible and as most normal as possible. Just a little bit about the levels of care, and this is Medicare, that says we have to provide these levels of care. And then there are patients, that we serve that aren't Medicare, but in general, most insurance companies follow the same guidelines as Medicare. So general inpatient care, our inpatient units, and that's for unmanaged symptoms or crisis. It's temporary. On average, I think I've been told it's a 3-day stay where the hospice is expected to get those symptoms under control, managed, and then return the person back to their home setting. Then home care, long-term care, that's what is often referred to as routine level of care. That's the day-to-day, keeping the person managed. Continuous care, again, this is for a crisis for unmanaged symptoms. It does happen one-on-one with the nurse at the bedside. Generally, the eligibility for inpatient care and continuous care are the same. It's just the setting that's different. Continuous care can be in a facility or at home, mostly at a facility. And then respite care is 5 days for any non-medical reason the patient can come to the inpatient unit. And a lot of times this is what makes a situation, makes taking care of somebody at home makes it possible for the caregiver. They just need a break because it is a 24/7 job for that caregiver, and respite can make all the difference. The second myth, a person should only consider hospice for the final days of life. And sadly, in reality, most people postpone the hospice decision until the final days or weeks of their life, even though it might have been mentioned earlier. And a lot of our education efforts are really, aimed at changing this perception and getting people in sooner. I don't know if you've heard, but one of the top comments that we receive on surveys after we've taken care of a person, the family or caregiver says, "Oh, we wish we'd had you sooner." And then people erroneously equate hospice with imminent death, imminent meaning, days or even hours. But a person is eligible in their final 6 months of life. That is the fact. And but it doesn't end after 6 months of life, as long as the hospice continues to document how the person is declining or unstable, they remain eligible. It could theoretically be for years, and sometimes it is, but it's on the, we have to prove that this person, it still looks like it is within 6 months. So every time the patient is recertified, that is a Medicare type word. That means like a re-up or reissue of the hospice care. It starts from that date that we're saying, okay, it looks like it's within 6 months. Again, the physician has to say that.
And Laura, I would just say that it's not like they're not evaluated within that 6 months. They're evaluated very periodically within that 6 months, like every 60 days or every 90 days, and they have to continue. So they could be let off of services within that first 6 months. True. If they're not still declining, right?
Yes. And just regulation wise, those recertifications are after the first 6 months, and then every 60 days after that.
Mhm.
They get the formal, certification, but as Lori said, they could be discharged at any time.
And last I heard, we had like a discharge rate of, I think it was like 16% of our patients will be, discharged in any given month. So that's why it's real important for us to have the palliative and the social connections programs, because often those patients, once they stabilize or they're no longer determined terminally ill, our volunteers can continue to touch base with them and if they enroll in those other two programs.
And that 16% that you mentioned, I actually was surprised when I first heard that number. That is right, like that is the national average, right around there. I didn't realize it was that high, but as a nurse, when I think back, yeah, it was. And I'll just say, as a side note, as a hospice nurse, you might think the hardest thing is, the death. And actually, for me as a hospice nurse, the hardest thing was to discharge a person live, because oftentimes it was, oh, we're getting kicked out of hospice. Sometimes people would be angry, but oftentimes they would be so disappointed because they had gotten used to the excellent care and just the regular presence. So live discharges are very difficult for the whole team. But when we have to, because, we have to follow Medicare regulations. And we're, I get off on tangents, but we're all taxpayers, and we want, we're paying for Medicare with our taxes, and we want it to go to the appropriate population. And if somebody is live discharged, we want them back when the time is, when it's appropriate. Was that a question, Lori?
Yeah, so the question was, when they discharge from hospice care, are they picked up by palliative care? And I think maybe you two can tag team on that answer.
Go ahead, Barb.
So they can be picked up by palliative care, because it's a different way, it's a different place that Medicare gets billed. The hospice benefit is sort of exclusive over here, and then palliative care as a physician service or a provider service is over here. Not everyone that comes out of hospice care necessarily has a palliative need, but we certainly can take those patients under care for an extra set of eyes. Same with social connections. So that's a non-clinical service that is provided by HOC navigators that stays in touch with the patient. So the short answer is yes, we can. Not every live discharge that comes out of hospice needs palliative care right out of the gate. But I would concur with Laura. It doesn't feel very celebratory when you have a loved one that gets discharged from hospice. And it's not because that's what the hospice wants to do. It's because the Medicare regulations are so strict, and just an FYI, have not been rewritten since they were originally proposed in the mid-70s, right? So there's really a lot of opportunity to update some of that, but that's another presentation too.
Yeah. So yeah, there's a lot of tears often when people enter hospice, but never has there been a yoo-hoo, I'm graduating from hospice. Never am I
Never.
happy about it. So just
Great.
about, how do you get in hospice? Well, you need a physician's order to enter hospice, but anyone can make the referral for information and to get an evaluation from a nurse. So anybody calling into our navigation center, they will, if they don't have a doctor who has given the order, we can go to our own physicians, we can pull the medical records, we can do that evaluation, and we can find out on our own, are they eligible, and get them in. And then another note is, as far as discharging, the patient can transfer out of hospice at any time for whatever reason, to seek more aggressive care, or sometimes people say, I'm doing so well, I feel like I don't need hospice anymore, and I don't want to, I don't want to Medicare to be billed or whatever, So whatever the reason, they're free to leave hospice. What was
Okay.
that the question, Eric?
No, that was it. Thank you. Oh, what
Julie
kind of
just put a
support?
question up.
What kind of support is offered to the family when a person is discharged from hospice?
Okay.
So what does
There
it? What
may
does a
be-
discharge?
There may be a referral made to social connections and or palliative care. The social worker on the hospice team works with the nurse to do discharge planning. That can be if they had durable medical equipment, a bed or oxygen, whatever they had through hospice. We work to provide that now outside of hospice through their Medicare or their insurance. We help them with their prescriptions of getting, when they're discharged, we generally provide a 2-week supply and get their prescriptions transferred, because a lot of those medications we've been providing. We communicate with the physician and anybody else on their care team outside of hospice so they know what's been going on. We give them a written discharge summary. I think, some other like Council on Aging, referrals to community agencies. That's the main things I can think of that we do when we do a live discharge. And the teaching, if there's anything that, the hospice team has been doing that now the family is going to be taking over, there would be a lot of education before the patient was discharged.
Excellent. Thank you.
Okay. Another myth, this one, not so much as it used to be, but was that hospice is for cancer patients only. And at one time it was true that the majority of patients receiving hospice care did have cancer. But now patients with chronic diseases are making up a large percentage of patients receiving hospice care. And just in my own experience, I would say that, just anecdotally in a caseload of patients, 25 to 30% of my patients would be cancer patients and the rest would be chronic diseases. So in fact is that it's for anyone who meets the criteria, regardless of their disease. It has to be life limiting, like we said, 6 months or less predicted. The family and the patient need to be informed that the condition is life limiting, that they are choosing this type of care for comfort, and then our responsibility to document clinically their disease progression. Here's some examples of all the different illnesses that would qualify for hospice, but really the last bullet point, any end-stage disease. Some of the primary ones that I think are heart disease, stroke, the end stage of a stroke. Sometimes a patient has had a stroke 10 years before, and it's just the consequences of that stroke over all the years. And then dementia, Alzheimer's disease, and pulmonary disease too, emphysema, COPD. All of those we see quite a bit of.
Laura, what kind of, with symptoms like dementia and Parkinson's that can be very, long diseases, what would indicate, what would somebody look for in terms of end stage? What type of functionality would they have?
Well, in general, I would say very limited mobility, like but there are exceptions to that. I mean, they could be confined to bed, but they're not, somebody doesn't have to be confined to bed. Difficulty swallowing is, a common one. There's no set, you can't say, oh, they must have difficulty swallowing. They must have weight loss, but weight loss plays into it. Significant weight loss is considered 10% or more over 6 months. Let's see, the appetite diminished, skin breakdown, significant skin breakdown is often a thing that's seen in like the neurological diseases and dementias. Loss of ability to speak or very little speaking. There are, you know, the criteria are in writing for those particular diseases as a guide, not that they have to check all the boxes. And, you know, if somebody ever wants to reach out to me to say, you know, I know someone who has dementia and I'm wondering if they're eligible, and we could talk it over, and I would say, oh, you know, no, they're too high functioning. I don't think they qualify. Or I say, definitely, I think they'd qualify, or, you know, maybe, you know, let's get an evaluation. So, and sometimes it's the rate of decline. Maybe somebody's been very, very stable for a while, and then all of a sudden they take a big decline. That could mean it's getting, you're getting into that end stage.
Another question, this one may be for Barb. Can someone with Parkinson's enter palliative care earlier in their disease process?
Yeah, if there's symptoms and or goals of care needs, yeah, absolutely. And I won't go into it. I didn't speak to the frequency of visits by the nurse practitioner. Typically though, we keep someone under the care of palliative care for about 4 months, 3 to 4 months. So it's a, you know, sort of come in, help with symptoms, help with goals, help with future. But if someone with Parkinson's has a palliative need earlier in the disease, the team would assess and help guide, and then probably at some point discharge them until there was another palliative need. And then the other thing I wanted to just add on to what Laura just said about those particular neurological diagnoses, dementia, Alzheimer's, Parkinson's, those conditions are under particular scrutiny from Medicare. So for long lengths of stay, and I think that's what makes it so challenging for us in the nonprofit hospice world, wanting to provide very needed care and trying to figure out, does this individual, it's not that they don't have need, but because there's so much scrutiny and so much regulation around those neurological conditions, sometimes it just puts everyone in a bit of an awkward spot. And then, you know, to Laura's point, someone comes in, they get care, and then because the regs are so tight, then they have to be dismissed from hospice. So that goes back to that policy need for some updates in how the hospice benefit is defined and carried out.
Excellent, thank you.
And you could also apply some of these regulations to the level of care discussion. When you talk about inpatient care and continuous care, you know, you know, let's say we got the symptom under control and we said, okay, we need to talk about going back to the facility or go back to discharging back to home. And, you know, and the family might say, well, what do you mean? He's not sick enough. You know, he can't control his bodily functions. He's not able to talk. He can't even move. You have to turn him in bed. You know, he's not eating anything for days. You know, so we really have to do the education, and that is the regulation right now of what qualifies for that level of care. So.
And I will say, I've got one more question. I know we're about 15 minutes out. So Laura, I don't know how much time you're going to need.
Yeah, okay. That was my alarm.
Okay, so but I will say, here's the question, and maybe you guys can tag team this again. It says, if the current hospice client count is 700 plus, is there a maximum number of clients that HOC could handle? Barb shaking her head. No,
nope.
No, there's not.
No, there's not a maximum.
Yeah, we grow as the need goes. We grow as the need grows. And so we just have to hire additional staff. We've had census very high, up to 800, and we've done some planning. I think some projecting if our client count reached up to 1,000, that I recall pre-COVID, we did some modeling of what that would require with staffing. And we've had instances where it has gone up significantly and the team has kind of taken on why we hired additional people. So we kind of stair step sometimes, it seems, but we adapt, and we adapt to where the need is, because that's part of our mission. So,
The closest that we've gotten to, saying there's a capacity is when our inpatient units all become full, which is very, 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 very rare.
Yeah.
I don't think it's
Yeah.
happened for years now, but, and then we work, we still take the patients, but they just, if there's not a bed in an inpatient unit, we have to come up with a different plan for their care. And usually if that's the case, they're put on a waiting list. Maybe they'll have continuous care at home, and we make a plan and we get them taken care of, whether they can get until they could get into the unit or.
yeah.
Okay.
Great question though.
Just
Mhm.
pretty much covered this, that it's difficult to sometimes determine eligibility for people with chronic disease, not only on our part, but also for patients and families trying to decide, is it time for hospice? And sometimes people have, been told that they're not going to make it out of the hospital. The family has been told, that their loved one is going to die, and they improved and were discharged. And sometimes that happens multiple times. So, you can see why they might not believe it, when they're told it another time, when it really is close to end of life. Chronic diseases have ups and downs. This is just one way, that we've educated physicians. If the physicians aren't sure about whether somebody is appropriate for hospice, if it's time, one thing to get them thinking is ask themselves, would I be surprised if this person died in the next year? And if the answer is no, then maybe that person is appropriate. Just get you thinking on that. And the same goes for, you as volunteers within your neighborhood and your family. Just if you, when you're with your relatives at a holiday and somebody is elderly and you see they've really changed since the last time you saw them, and you're wondering, is it time to even start thinking about end of life plans? So it just, in reality, the length of stay, meaning how long people are in hospice, is decreasing. And we, to help people more, we wanted to go in the other direction. Some people we do have very long, but some we have not even 24 hours. So the average is going down.
And I would just add to that our volunteers have seen that change as well. People are having shorter stays in the inpatient care center, that if you're a concierge and you're volunteering 1 week, the person's usually gone the next week. It used to not be that way. Yeah. And then also just the fact that people are, they're declining so quickly. You may have a very, lucrative visit 1 minute, and the next week you could hear that the person has passed. It's just very acute if people are coming to us. Yeah.
And then in our society, talking about end of life and hospice care in particular is very difficult, and it's often avoided. I have, I'll just say with my parents, two opposite ends. My dad, he welcomed the discussion, years before he was at end of life. And his way of saying was, I don't want any of that baloney, and I don't even want an obituary. And if you insist on an obituary, and his name was Richard, he said, I just want it to be Dick died. That's how, that's how he felt about end of life, no baloney. And my father did die at home, and there was no baloney. But my mom, she's 87, and it's a different mindset. And she just weeks ago, in fact, she probably still has pneumonia. And this is her first serious illness really ever, not hospitalized. She came to my house for a few days just to make sure she stayed on track. She does not have her advanced directives, and I brought that up, and she's not comfortable with it, so it's just baby steps, and everybody's at a different place with that. And then I mentioned people wish they'd enrolled sooner in retrospect. Oh, and then why do you might say, well, why do people want things that, really aren't appropriate? I see sometimes people will put it in compartments, such as like high blood pressure. They see, oh, well, let's just get the blood pressure under control, not even taking into consideration all the other organs that are involved. It's not easy for, people not in the medical profession to understand their condition, the seriousness. And there's a lot of times there's multiple physicians, and one physician has fixed one part of the body, but that doesn't mean that the rest is fixed. And there's conflicting information. One doctor might think it's not time, they've still got plenty to do. And so there's a lot of reasons why treatments that are really futile or inappropriate can occur. Another myth is the person must give up their medications, their treatments, their physicians to enroll in hospice. None of that is true. Their medications are continued. Sure, we try to, if it's something that we think could adversely affect their comfort or their condition, a medication will talk with the physician, make that recommendation. But really, if the patient ever doesn't want to stop it, they don't have to. They get all the medical equipment they need. So on these therapies, speech, physical therapy, and occupational therapy, yes, they can coexist with hospice, but it's limited. It's different. The reason is not for rehabilitation. The reason is generally for a little bit improvement in functioning, a lot of times for safety. Speech therapists help with swallowing. So generally, maybe we contract out for those services. I'd say 3 to 6 visits from those disciplines is what could happen with hospice. And the medical director does have to approve that and feel like that is, needed. We do feeding tubes. We don't start feeding tubes that I know, but we will continue them. IVs, we do them in certain circumstances. To maybe somebody has had intractable nausea or vomiting, and just to keep their fluids up until we get their nausea and vomiting under control, that might be. Okay, so looks like I got about 5 more minutes, but just know that in blood transfusions, radiation, so the bottom line is these treatments are done when they provide patient quality of life and they're consistent with the goals of care. And then we do encourage that the patient's own physician be their attending physician. Some say, no, thank you. Your hospice physician, that's their specialty. I would rather that they be the attending physician, but we do always ask. Yes, Lori.
I was just going to add too, they do not have to sign a DNR to take hospice care.
No.
That is something that we have, conversations around significantly, because most people don't understand what not signing in a DNR means. If they do not sign a DNR, they are still enrolled in the program, but we would have to call the squad and they would have to sustain chest compressions and different things for over 15 minutes, I think it is. And it's a pretty significant thing, but it is not required. The other thing is that we now have a ventilator withdrawal program. So we will have patients that potentially come to us from the hospital to our inpatient care center, where they are withdrawn from the ventilator here at our unit, which is a more conducive setting to having family present and more support. So that's something new since COVID.
And then we accept patients with LVADs, LVAD, that's a left ventricular assist device. And we will deactivate them if that's what they want. We had one recently. Lori was intimately involved with in the volunteers. There was another, and inotropes like dobutamine and milrinone. Those are cardiac drugs that are, that we do take care of those patients as well if they're end stage. The benefits, you've got the physician medical director services, the routine nurse visits I'll just say routine nurse visit is once a week and as needed. Sometimes people request less often, but Medicare says it has to be at least every 2 weeks. We're available 24/7. The bereavement services are available. That is free through a grief center for at least 13 months. All their medications that are related to their terminal diagnosis are provided, and the equipment and related supplies for care needs. That's things like incontinence supplies, dressings, wound care. And then the other very important service is support for the caregiver, giving them education on how to take care of the person. Really, when you're a home care nurse, you're teaching the family how to be a nurse. You know, they're basically earning their nurse's cap, knowing how to take care of that person. And then all the support that you give them, the whole team, spiritual, emotional, the social, the agencies that we might get involved. We're there for crisis and then for bereavement. And I just always like to bring a face to, with a couple little stories.
We're almost at the end of time. Oh, there you are. Okay, you want to finish with the story? Go ahead.
Sure. Well, I'll just show you these people. The point of me showing you these pictures, and this is generally given to the public who picture patients as being on their deathbed. And all of these pictures show that they're very full of life. And this fella, he was in our cardiac disease program. He had end-stage heart failure, and his doctor gave him a prognosis of a week or two. And he was with us, I think, 9 months, very full of life.
Wow.
And
Excellent.
then Maxine and Norma, Maxine, she was 100. I think she was over 100, and she was discharged by hospice, a live discharge, because she was at over 100. And I was involved with them through social connections. And then one day, when I would just do monthly check-in calls. That's what they wanted. And I called Norma, and she said, "Oh, I'm so glad you called. My mom said this morning, we need to get some oxygen in here tonight." And she said, I had no idea she was even having any trouble breathing. And literally within hours, we had a nurse out there admitting her to hospice, found her eligible again, got her the oxygen, and actually she went on to live a few more months. It wasn't a crisis, but she was appropriate at that point. But both very full of, Maxine, how full of life she is there. And then I did not know this gentleman, but he was in our inpatient unit, and you can tell by looking at him that he's very sick. But look how much life is in him, and you know what he's looking at. The picture I think I don't have here is that his family is on the other side of the window. This was during the time of the pandemic, and there's a picture of him with the phone up to his ear, and he was talking to them as they were on their cell phones. And then Dame Cicely Saunders, if you don't know of her, she's considered the founder of hospice in England, and she was a physician, a nurse, and a social worker. And she said, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." And that, I'd have to admit, that photograph is a stock photo. But I've had so many patients that just look so full of life that fellow exemplifies many people I've taken care of. That's it. So,
thank you so much, Laura and Barb. I'm going to give you a round of applause, everybody. This
right
has been so incredibly helpful. Thank you for launching our first education session. I want everyone to write this date down, February 13th, again at 10 a.m., 10 to 11:30, we will welcome Trent Holden, who is one of our chaplains, who will work with us on spiritual care and life review, answering those 10 common questions that all humanity has around end of life. So we get the the professional view and answer to some of the world's most wondering questions. And it'll be a great session and will count as our second class for doulas. So thank you all. I really appreciate it. I'll be sending out a link to the video and also the PowerPoint and a follow-up survey for everyone to give us their comments on presentation. So thank you.
Thank you.
Bye-bye.
Thanks, Lori. Thanks, Laura. Bye.